Assalamu alaikum. The short clinical station day. The first scenario, Mr. Ali. He is 40 years old. He came for follow-up. Please examine his chest. Yes, here you go now.
Good morning. I'm Dr. Henry. May I confirm you are Mr. Ali, 40-year-old?
Yes, doctor.
Okay, you're welcome. Do you mind if I examine your chest, your face, your hands, and your leg? Okay, can I go ahead?
Okay.
All right. I want
Yes,
to
you
look
can.
at I want to expose my patient very well. Look at the surroundings, check for any inhaler, check for any steroid card, and check for any medication, check for any oxygen in
No
nasal plug.
significant.
Not lovely. So please, can you stretch your hand, go to the foot of the bed, and then ask the patient to breathe in and out, check for any expansion, any reduced expansion. Can you please cough for me and check if it's a wet cough or dry cough? Is it wet or dry cough? Then go to the
Yes,
side.
just hiccup.
Pardon?
Yes,
Is it
hiccup.
wet?
Just dry.
Okay, dry
Yeah.
cough, lovely.
No,
And
no.
go to the side of the patient. Can you please stretch your hands? Check for any tremor.
Before that, when you are looked to the chest, there is asymmetrical in the left side
Left
of the chest.
asymmetrical in the left. Okay, the left is
Yeah,
left. The left is
Yeah.
okay. Okay, the left. Okay.
Mm.
Then can you please stretch your hands? Let me see. Check for tremor. Then place your hands on my palm and let me look at your hands. Check for finger clubbing. Any finger clubbing?
No, negative.
Look at the joint. Any ulnar deviation? Any change in joints? Any joint problem? Any pain? Tender joint? You feel any pain here? Check for tar stain. Check for no tar stain. Lovely. Then palpate the pulse and check for the respiratory rate within 10 seconds. Do that. Then do you have any pain in your tummy?
No.
Then can you look at your left? Let me check for your JVP. Then I check any JVP is elevated. Is the JVP elevated?
I didn't. JBB not elevated. Yeah, not
Okay.
elevated.
Then use your hands to bring down your eyelid. Check for any pallor. Any pallor, any jaundice. Okay. Okay. I want to touch. I want to touch your neck and check for your windpipe. If you feel, you might feel a little bit discomfort, but I'll try and be gentle and check for any the trachea is central.
Okay. Yeah,
Check
the trachea.
Is central. Okay. Okay. Then
no, the trachea deviated to the left
to
side.
where? To the left side. Okay. Okay, good. Then after that, I will go to the back of the patient, check for the lymph nodes from the back, any lymphadenopathy.
No.
Okay, then check and go to the back and check for expansion in the apical, middle, and then lower lung zone. Any expansion, is it reduced in the left?
Yes, the chest expansion is reduced in the left side mainly.
Okay,
but
then
normal in
check
the right side.
Okay, then check for the tactile phemictus, left, right, left, right, left, right, anything. Tactile phemictus. Can you please say 99, 99, 99, 99 on both sides? Anything?
No, regarding if you want it by auscultation, yes, there is a decrease in the focal resonance in the left side.
Okay, okay. Then I want to percuss the both sides laterally.
Doctor, I'm sorry, yeah, there is a scar when you are looked to the chest. There is a scar, left thoracotomy scar.
Okay, left thoracotomy scar. Lovely, thank you very much.
You are not asking me, that's why.
Yeah. Okay, thank you for that. Thank you for that. Then you look at it. Okay, then percussion, anything on percussion? Percussion, anything on the percussion,
just
anything.
Then, yeah, dull in percussion, the left side.
Dull in percussion, the left side. Okay, then
yes.
Then auscultation, anything auscultation?
Auscultation, yes, actually there's absence of breath sound. Just when you are going to auscultate in the upper or in the apex and the upper part of the left chest.
In the upper part
You
of the
hear
left.
bronchial breathing, yes.
Okay, in the upper part of the left, there's bronchial breath sound.
Upper
right?
part, yeah.
There's bronchial breath of the middle and lower part.
The lower part, no breathing.
No breathing. Okay. Okay, then go to the go to the front. After doing the vocal resonance, go to the front, do the same thing in the front. Anything? Any changes in the front?
Any change in what?
Any changes? The same findings I got in the back. I
In
do
the
the same
front,
thing in
in
the
the
front.
front.
Any changes?
Yes. The
Okay,
same,
1
the
minute
same.
left.
Okay, so after then I'll thank my patients, then wash my hands back again, and then use the left minute to digest what I have to say before I face the examiner. Then I'm thinking what I'm about to say now. Okay.
Okay.
Maybe before I continue, I'll just check the no PD edema. All right.
No, negative, doctor. Okay. Anything you want to do it?
Okay. The scar. Look at the scar. Where does the scar extend to? Do you have any image, any picture of the scar with you?
Yeah, Dr. Basim, he sent the picture.
Yes, in the chat box you can see it. But I think this is the right side, Dr. Sarah, not left.
Yes, just I'm sorry because I didn't find the imaging.
You saw the picture, Dr.
Yeah, I've seen it.
Okay.
I've seen it. Okay. So I'm done. Thank you very much.
Okay, examiner
Yeah, there's
questions.
two small scar also. Okay, so could you please present your case for me?
I've
The finding.
examined Mr. Ali, Mr. Ali, a 40-year-old man who on physical examination and noticed a lateral thoracotomy scar in the left, however, with reduced expansion on the left and reduced expansion in the left.
Dr. Hina, it's right side. To be
Okay,
matching
right.
with the picture. You can see the right side. This is the back and the right side of his back.
Okay, so the scar is at the right, while the findings is at the left.
No, it's
Okay.
by mistake. Yeah, it's right, and
Yeah.
everything will be in the right.
Everything will be in the right. Okay, thank you.
Obviously it's right. Okay.
Okay.
Continue, please.
Thank you very much. So there's I noticed there's on the physical examination there's right thoracotomy scar with reduced chest expansion on the right side and decreased tactile firmitus with dullness on percussion and no any she didn't tell me the crepitation if there's any. She
No
didn't mention.
crepitation.
Okay, no,
Okay.
okay. Okay, so looking at my examination, my provisional diagnosis here is in keeping with right, it's right thoracotomy scar with underlying numeric with underlying lobectomy likely due to with a right thoracotomy scar, probably due to a right lobectomy. Differentials of maybe due
Okay,
to
what is the differential diagnosis for lateral right lateral thoracotomy scar, doctor?
differential diagnosis could be due to maybe
in this case,
in this case maybe due to trauma from the maybe a blunt trauma, a sharp trauma from maybe a knife trauma. It could also be due to lobectomy. It could be due to lobectomy. It could be due to decortication, probably plus fluidity. Could be also be due to bulectomy. It could be due to lung volume reduction surgery. It could also be due to it could also be due to
okay, well, doctor. So doctor, regarding your finding in the chest examination, you are finding that there is a reduced chest expansion in the right side and also dullness in the percussions. And on auscultations, you find decrease in the focal resonance also. So when you are collect all together, so can you put the differential diagnosis for this patient?
Yeah, with the reduced tactile vocal formations at the right side, and then with bronchial breath sound, basically maybe seen.
Yes, what the differential diagnosis as general, instead if you have a scar or not?
Yeah, if there's no scar, I'll more likely think of a collapse in that area. If there's no scar, I think of a right lung
Okay,
collapse.
anything else?
Yeah, and if there's no scar too, you could be due to effusion, maybe pleural effusion. Pleural effusion because of the dullness, and due to
Okay.
pleural effusion. Could also
Okay,
be due
so
to,
you can put lobotomy, pneumectomy, pleural effusion and collapse. You mean that?
yes.
Okay. Okay, excellent. Okay, so could you mention for me, please, the cause? The cause of lobotomy or the underlying
Lobectomy.
cause of lobotomy or pneumectomy in such a patient.
Okay, the cause of lobectomy could be due to localized bronchiectasis, could be due to underlying lung cancer, could be due to pulmonary tuberculosis, it could be due to probably due to lung abscess. It could be also be due to underlying cause, maybe due to lung abscess, and also it could be due to physically cancer. Okay, trauma.
Okay. Thank you, doctor. Okay, so could you please mention for me the investigation for this patient?
Yeah, investigation looking at this patient that's coming for follow-up. We want to do serial pulmonary function tests, which will include the lung volume and capacity, and then the DLCO, which is the efficient, DLCO. Then also arterial blood gas arterial blood gas, and if because of the fact that he's coughing, we need to analyze the sputum analysis for MCS, sputum culture, sputum AFB, and then also sputum fungal study depending on the line cost. Then also for blood tests, maybe patient will be from full blood counts, differential full blood count and differential lateral and creatinine liver function tests, and then also other imaging tests may include chest X-ray and high resolution CT scan, and then if need be, maybe to invasive test, maybe bronchoscopic and bronchoscopic plus maybe
All of
bronchial
these
alveolar lavage.
investigations, you mean you are going to do for this patient, doctor?
No,
Yes,
not
your
the
patient
underlying
came
cause.
for follow-up.
Okay, for follow-up, basically for follow-up, I will just my pulmonary function test, which is a force volume and capacity, and then peak
Okay,
flow.
so what's the finding in the pulmonary function test you
Pulmonary
suspect
function
in
test,
this?
in this case, I will expect to get a restrictive pattern in which there will be, if the FEV1 over FVC will be
Okay.
will be normal, and then they will reduce all lung volume, other lung volume and capacity.
Okay, so what do you think the cause of this scar in your patient? Is it lobotomy or pneumectomy, doctor?
Basically, looking at the scar is most likely to be because of there are some findings in the upper lobe. So I'll think of lobectomy because of because there are some good findings in the upper lobe. So I'll go with lobectomy. Yeah, I'll go with left
Okay.
lower lobe lobectomy.
Okay, so what is the cause of the bronchial breathing in the upper of the chest or the lung?
Because of the upper lobe, most likely this is the disease condition. Probably there's the lower lobe was excised, and then the disease is still manifesting in the upper lobe that is not excised, basically.
Okay, so thank you, doctor.
You're welcome.
Okay, thank you, Dr. Henry. Well done. Dr. Sarah, can you comment now, please?
Yes, regarding his examination, he did well. Regarding his presentation, I think just he missed the trachea. He didn't comment regarding his deviated. Also regarding the differential diagnosis, yeah, it's okay. And other the discussion, yeah, he's good. Just in this patient, yes, it's most likely pneumonectomy, because when you are auscultate in the right side, yeah, there is no breath sound at all. Just no ventricular breathing, no any. So just you are auscultate and you are listening for breathing sound in the upper, because the deviation of trachea itself. Okay. So the bronchial breathing is from the trachea deviation just. Yeah, apart from that, I think you mentioned all the differential is fine. Regarding the scar itself, yes, it could be lobotomy, it could be pneumonectomy, it could be lung volume reduction surgery, it could be blocktomy also, and also it could be yes, single lung transplant. Okay.
Okay.
Regarding the differential of reduce the chest movement and dullness in the percussion, and also decrease the focal resonance, yes, you are right in the differential. You can put lobotomy, pneumonectomy, and pleural effusion and lung collapse. Okay. So yeah, you did fine. I didn't have any comment apart from that. Thank you.
Thank you, Dr. Sarah. Yeah, I think he did well, as you said. Apart from trachea examination, did you mention, Dr. Henry, how to do the trachea examination?
I did,
He examined, but
I
he
did,
didn't.
I did,
Yeah.
but I didn't say it. I didn't say it when I
Yeah.
was mentioning my
Yeah.
findings. Yeah.
Yeah, so you have to mention to the patient it will be discomfort for you, the feeling. I will put my finger here. Don't worry, I will be try to be gentle, because it's very discomforting to feel it. If you try on yourself, you will feel some annoying pain. Okay, you have to
Yes.
mention it. I'm going to examine it, and I will try to be fast and as gentle as I can. The lymph node, I think you miss as well.
I checked.
You checked, okay. So in the chest examination, you have to examine for the cervical, auricular, anterior, posterior, as well as the vertical. Otherwise, you have to point to the scar itself over the chest from the beginning till the end of the scar. If there is two ports scar, you have to mention. However, in this scenario, it's not there. The indication, yes, we repeat it twice and it's correct. Pneumonectomy, lobectomy, or pleurectomy, or as written, wedge resection. However, the wedge resection is smaller. You can do it with the smaller one. And the lung transplant, single lung transplant. I think these are the indication. How to differentiate this very important question I will ask Dr. Henry. How to say this is lobectomy or pneumonectomy?
Yeah, in lobectomy, there's usually normal findings in the other lobes, or probably there's if it's due to, or maybe there's if it's due to, there'll be hyperinflation in the upper lobe preceding the lobectomy. That will give you an idea that this is a lobectomy. And also in lobectomy, in pneumonectomy, the whole lungs in that particular side will be affected. So there'll be dullness all through, and then there'll be absence of breath sounds, and basically these are one of the difference between the two of them.
Yeah, so you cannot hear any breathing sound at all in this side for pneumonectomy. For the lobectomy, eventually you might find some breath sound, particularly if you have the lower lobe resection. So you might have upper lobe or air entry. Okay. The other thing for pneumonectomy, uh, there will be shifting or deviating trachea
Yes.
towards toward the affected or the excised side. For the lobectomy, suppose it's not deviated, but some cases in the acute setting after the surgery, yes, sometimes the trachea could be deviated. Okay, again, toward the side of resection of lobectomy. So initially it will be until there will be hyperinflation of the other lobe. That time the trachea will be centralized. Okay. So
Yes.
sometimes they are saying in pneumonectomy, if they fill the area of lung with cement or substance, the trachea might be centralized. However, commonly, you have to talk about the most common. The most common, it will be deviated toward the side of pneumonectomy. The other important question, when to do the lobectomy, or what the contraindication, another way, when to do that, when what's the contraindication of lobectomy and the contraindication for pneumonectomy.
Is it okay? The contraindication for pneumonectomy, usually you look at the volume. The volume should be in lobectomy is usually less than 1.5, while in pneumonectomy is usually 2. So for 2 and above for pneumonectomy, while 1.5 and above for lobectomy.
Yes, so yes, almost you are saying the correct answer. So they have to do the vital capacity. If it will be affected more than 1.5, the total, they will not do it. Oh, sorry, they can do it. If less, they will not do it.
Yes.
Okay, this is for the lobectomy. For the pneumonectomy, if more less than 2. Clear?
Yes. Yes, sir.
Yeah, this is another difference. They might ask you how to differentiate and what the contraindication. The other investigation, the pneumonectomy scar would be much wider and bigger.
Wider.
Yeah, the lobectomy might be smaller than the pneumonectomy scar. Okay.
Yes.
Yes. They might go through the indication. What about the cancer types? Do you know?
Cancer.
And
Okay. Cancer can
go ahead.
cancer can be divided into small lung cancer and non-small lung cancer. The small cell, the histological type, which is the small lung cancer, is just one. Then the non-small cell cancer are further divided into large cell cancer, squamous cell cancer, neuroendocrine tumors, and adenocarcinoma. Yeah.
Yeah, so you have to say either small cell or non-small cell. What's the difference between the small cell and non-small cell? What
The
the
difference,
most criteria? Yeah, most important criteria for a small cell.
for small cell, typically there's usually they have more of they have more extra pulmonary manifestations such as ACTA secretion, and then they may have things like ACTA secretions, unlike the not the large cell cancer that may be due to. Then also the things like Lambert-Eaton syndrome is also seen in small cell cancer, and which is not seen in other large cell cancer typically. For the management options, the small cell cancer usually is basically surgery is not, is not usually indicated because it tends to present later and there because of the small size. Then in non-small cell cancer, usually if it presents early, surgery is usually indicated for other management options.
Yeah, so the most important to mention for the small cell lung cancer, whenever it will be discovered, it might be advanced and already invased and spreading, right?
Yes.
So the patient will not be candidate for any chemo or radio or even surgical resection. However, for the other, so in this case, would you think the scar will be a case of small cell lung cancer?
In the case of small cell lung cancer, you may not see any. The small lung cell cancer, you may not see any scar. Or probably may see other scars such as
Not
your
scar. He will not be. The patient will not be candidate for surgery.
surgery. Yeah.
Once you discover the cancer, the small cell lung cancer with histopathology or bronchoscopy, the patient will be already metastasized to everywhere, and the chemo or the radio will not be effective, even the surgery. So I don't think the surgery will be fitting for those patients. So difficult to say, but you have to mention the types of either small cell or non-small cell. Okay, regarding the non-small cell lung cancer, what are the possible types? What are the types you know?
The non-small cell cancer. The
Yes.
possible type is squamous cell cancer, squamous cell, also adenocarcinoma. It could also be large cell cancer, and then it could be neuroendocrine tumors such as carcinoid, bronchial carcinoid, and the rest of them.
Yes. So squamous cell and the large cell cancer. Add to them, what are the other type of cancer which is not as a lung cancer per se, but it's cancer happen in the bronchi.
Yeah, it's carcinoid, bronchial
Yeah, so
carcinoid.
neuroendocrine in the form of
Tumors.
carcinoid. Exactly.
Yeah.
Otherwise, you might have metastasis from others, secondaries, I mean. So these are the differential diagnosis of lung cancer, which can be a question. The other question for the lung cancer, the paraneoplastic. They might ask you and before that, what are the most common cancer for smoker?
And the most common cancer for smokers typically are the
Yes,
squamous cells and
Yes,
squamous cell
squamous.
carcinoma.
Exactly. And for the non-smoker, the most common?
For the non-smoker, the most common is adenocarcinoma.
Exactly, yes. And what are the centrally located cancers in the lungs?
The centrally located cancer, the small cell cancer and the squamous cell
Yes.
cancer.
Yeah, so
Both
any
squamous
S
and
or C, yeah, or S or C. However, the A or any letters other than S will be the peripheral, like adeno or large. It will be peripherally located. One more question. So, what are the paraneoplastic manifestation of the lung cancer? You know?
Lambert-Eaton syndrome, is one of the paraneoplastic syndrome. Then also parathyroid related parathyroid related peptide, parathyroid hormone related peptide, manifestation, also paraneoplastic. Also other paraneoplastic syndrome could be also myasthenia. Let's see. Then ACTH as a paraneoplastic syndrome too. ACTH secreting tumors.
Yeah, Cushing in the form of Cushing.
Yeah.
So ACTH,
Cushing's, yeah.
yeah, ACTH, antidiuretic syndrome of inappropriate
Yes.
antidiuretic hormone,
SIDH.
SIADA,
Yeah.
and Lambert-Eaton. All these for small cell lung cancer. Although remember, although it's small, but it secretes a lot of proteins. Okay. The other question for the other types, the squamous will be secreting what?
Too much parathyroid related peptide.
Yes, exactly, and it will lead to.
It will lead to this hypercalcemia.
Exactly. Don't forget the Lambert-Eaton also with the small cell lung cancer. Okay. So the
Yes,
patient
sir.
will be presenting as myasthenia gravis, but as the incremental instead of decremental effect.
Yes, sir.
Okay, yeah. So the contraindication again, less than 1.5 liter for the forced expiratory volume 1 in the lobectomy, and for the pneumonectomy, less than 2 in the forced expiratory volume 1 for the pneumonectomy indication. Okay, the last question I will ask Dr. Henry regarding the other contraindication. What other contraindication for pneumonectomy or lobectomy?
Other contraindication is evidence of active cigarette smoking.
Again, what?
Active cigarette smoking.
Exactly.
Active cigarette smoking.
Yeah. Still resistant smoking, or
Yeah. then bleeding tendency sometimes.
So you can say related to the anesthesia, related to the surgery,
Yes.
obese patient. So you have to mention other contraindication related to the surgery or anesthesia, or even compliance to the medication. Do you think you can do it for a mental retarded patient? For the
Yes,
compliance, yeah, it's contraindicated. Okay, the obesity, difficult to do the surgery, or as you said, patient insisting for smoking. Okay, or advanced cancer like small cell lung cancer. You will not say I will do the surgery. Clear?
Yes, sir. Yes, sir.
Yes. Okay. I think this is the question. These are the questions. Anyone want to comment or to add any suggestion or to add any information? Feel free.
Yes, Dr. Bathim, just regarding how to differentiate between the lobotomy and pneumonectomy. Please, could you repeat it?
Yeah. So
With
the
examination.
trachea will be your clue, mostly because earlier or in the past they are not putting anything in the area of the pneumonectomy or lobectomy. So for the pneumonectomy, eventually the trachea could be, or mostly it will be deviated toward the side of pneumonectomy. Plus the finding of examination. You will have dullness, you will have the decreased air, diminished air entry, you will have the decrease vocal resonance, right? These are, and also bronchial breathing, as you said, but bronchial, keep it for lobectomy because you might have some bronchi. But in pneumonectomy, they will not have any bronchi. So these are the criteria for pneumonectomy. The clue will be in the trachea. The trachea will be significantly deviated or shifted toward the side of the scar. For the lobectomy, eventually, as I mentioned, the trachea will not be deviated
In the
unless
upper lobotomy, yes, it can be deviated trachea.
in the early stage.
Mm-hmm.
However, later on, with the lung hyperinflation or expansion, the trachea might be centralized. So you can focus on the part of trachea while doing examination. And the other finding, you might have air entry, might have bronchial breathing, you might have vocal resonance, you might have resonance or percussion. But pneumonectomy, be sure that nothing will be in the side of the scar. Plus, the scar size will be bigger, more with the pneumonectomy, and with the lobectomy, the scar will be little shorter. Okay.
Okay. So when I find the scar in the examinations, so also should I think the cause of this, if it is lobotomy or pneumonectomy?
Again, if
Yeah, during our examinations, when I
yes,
find it in the exam, I mean,
yeah,
just also we need to think regarding the cause behind it.
yes,
Yeah, I'm going to search also if for bronchiectasis or fibrosis or
exactly,
another.
yes. If there is, as Dr. Henry mentioned, like localized bronchiectasis, so you might have other side bronchiectasis, or you might have the hyperinflation of the upper lobes. So it might be like COPD patient with lung reduction surgery. You might have the other finding of smoker like nicotine staining or clubbing. Okay, all these things can give you a clue.
Okay.
Okay, Dr. Marwa commented here, and I comment upper and lower lobectomy. The best clue is to percussion in the axillary area, below and above the scar. Dull above is upper lobe, she mean lobectomy. Below the scar will be lower lobe lobectomy. Yeah, so these are this comment, Dr. Marwa, for the past or old-fashioned lobectomy. I think nowadays they can do a good fill of this is the area side of lobectomy. So I think the scar also might be lower bit, little bit, but it's usually we have a patient, old patient with previous history of lobectomy. So you can apply this whenever you do the percussion above or below the scar. You have you might have the either the dullness above the scar. This is upper lobe. Below the scar, this is lower lobe. Okay. But the most important to mention,
Also, the
there is
trachea in the
an entry.
upper and the
Yes,
lower, can be
yeah,
differentiated.
can be, as I said, yes, mostly the trachea might be deviated or shifted with the upper lobe, lobectomy, I mean. But eventually, sometime with the hyperinflation, the trachea might be centralized.
Yes,
And
doctor, and sometimes also could be lower lobe lobectomy and upper lobe fibrosis. The trachea will be shifted.
yes,
And
this is another
this is
implication with another pathology. Definitely, you're right.
yes.
Yeah. So you will have the fibrosis, and it will be in this way. You're right. As you said, you will have bronchial breathing above. I mean apically, and you will have high increased vocal resonance apically, right? And you might have the trachea shifted due to the fibrosis itself. Clear?
Yeah, clear.
In the lobectomy, yes, always should I find bronchial breathing above the scar?
Yes, as Dr.
Or what?
Marwa mentioned now, you might have another pathology, but mostly there is bronchial breathing. Okay.
Mhm.
Unless there is, for example, distracted lung, you might have, I think also it will be bronchial, right? If there is distracted lung apically, so you might have also bronchial breathing. Still, you have bronchial breathing. Clear?
Okay.
Any comment, Dr. Marwa, you want to add?
No, doctor, thank you. Yes, thank you.
Okay, this is the only situation you might have deviated trachea with lower lobectomy, with, for example, apical fibrosis or distracted lung complicated to, or the TB complicated, or complicated to the TB, tuberculosis. And of course, you have to have another finding of TB, like cachectic patient, you might have lymphadenopathy. Okay, so you might have all these things. Don't forget about the peripheral signs, nicotine staining, or the cachexia, or muscle wasting, all these things. Okay. Any other question before moving to the second scenario?
The most common other finding with lobectomy or neonectomy, bronchitis and what?
For lobectomy and pneumonectomy?
Yeah,
Cancer.
lobectomy with bronchiectasis or what? And other? Apart from bronchiectasis, the common in the exam, I mean.
Cancer.
Mm.
Cancer or distracted lung as before, or even fungal or lung abscess, or sometimes also hemoptysis. You can put as a differential if patient has acute hemoptysis and the patient is difficult to control with failure of the embolization, for example, they might take him for lobectomy. Okay. Or trauma. Some patient with trauma also, they might have lobectomy or even pneumonectomy according to the lung injury or the destruction itself. Clear?
Okay.
Okay, any other question? Yes, bronchiectasis, of course, you have to mention. COPD also you can mention. Any lung pathology you can mention as indication for the lobectomy. Localized bronchiectasis, yes, you can do it. But for bilateral bronchiectasis, supposed to be lung transplant rather than being as unilateral or pneumonectomy. Okay, so the patient mostly he will have bilateral or double lung transplant. Other pathology, as I said, any cavitary lesion like lung abscess or fungal ball And for the lung cancer, you have to mention definitely lung cancer, one of the possible. So the patient removed or they have removed the cancer earlier. And you have to mention the types, as I said, which are possibly having early discover without metastasis. Okay. Clear now for all. Let's move to the next scenario.
Okay, Dr. Basim, I've sent it to you.
Yeah, I can see. I will copy, then we'll start.
Copy the second image, not the first image I showed you. So
the second image.
So yeah, because the first image is she will get it easy. The second
okay,
image.
so the second image, you mean?
Yes. Yeah.
Okay. Yeah. Okay, Dr. Sarah, this is your scenario. 50 years old. John Smith for follow-up chest clinic. Reset the timer. You can start now.
Okay. Hello.
Hi, doctor.
Dr. Abdulkareem. I'm one of the doctor covering the service today. So may I confirm that you are Mr. John, 50 years old?
Yes, doctor.
Yeah, Mr. John Smith, we are here to examine you. During our examination, if you feel any pain or discomfort, please let me know. Is that okay with you? Hello? Hello?
Yes, we can hear you, Dr. Sarah. Dr. Henry?
Yes, because he's... Hello?
Waiting for Dr. Henry.
Okay.
Okay, we will reset the timer anyway. We will wait for Dr. Henry.
He sent any picture, Dr. Basim?
Yes, he sent it.
Where is?
Okay, I will post and you have to be ready.
Okay.
Dr. Henry, you are here? Dr. Henry, please.
Might be connection error or what?
No, he's not joining.
Yeah.
Dr. Henry, Eugene back. Okay, we can restart back.
Okay.
Dr. Henry, yes. Dr. Rasaridi.
Okay. Okay, so I will enter the room and I wash my hand. So hello, I'm Dr. Abdul Karim. I'm a doctor covering the surface today. May I confirm that you are Mr. John Smith, 45 years old?
Yes, doctor.
So we are here to examine you. Is that okay with you?
Okay, doctor.
So during our examination, if you feel any pain or discomfort, please let me know. Okay?
Yes, doctor.
Okay, so please expose your chest for me.
Okay, I've done that.
Okay, so I'm going to look for the surrounding. If there's any significance, any sputum pot, any oxygen cylinder,
No,
any inhaler besides the patient.
no.
Okay, so the general look if there's any significant. Okay, so I'm start examining the hand of the patients.
Okay.
Please show me your hands. I'm going to look if there's any clubbing.
No clubbing.
Okay, so the palm of the hand, if there's any palmar eczema or any significant joint deformity or other things.
Normal.
Okay, so I'm going to please could you please spread your both hand for me? If there's any fine tremor.
No fine tremor. Normal.
Okay, the flapping tremor.
No.
Okay, so I'm going to check the eye if there's any bella, any jaundice.
No. Normal.
The mouth, if there's any central cyanosis or any. Okay, so I'm start to examine the JVB. If it is.
GBP normal. Not raise.
Okay, I will do hepatogen reflex to confirm that.
Normal.
Okay, so I'm going to look for the chest if there's any. The patient is a 45 degree. I'm going to check the chest if there's any scar, any deformity in the chest
Yeah,
from
there's a
the
scar.
end of.
There's something behind at the back. Dr. Bazin will show you.
What?
There's a scar at the back.
Okay, the scar in the back. Okay. So I'm going to look from the end of the bed. Please, could you please give me a cuff?
No, cough. Cough is dry. No cough.
Okay, so regarding the chest movement, is it symmetrical or the chest shape or asymmetrical or not?
Yeah, it's normal. It's symmetrical.
Okay. Okay, so I'm going to palpate the apex. I'm warm my hands, palpate the apex.
Okay.
So
Nothing.
it is in place or not?
Normal. It's normal.
Okay, so I'm going to for second heart sound. Is it palpable or
Yeah,
not?
it's normal. It's normal. Yeah.
Okay, the left parasternal heave.
No, it's normal. No personal heave.
Okay, so Mr. John, I'm going to examine your windpipe. It might be a little bit discomfort. I'm sorry for that. So I'm going to check if there's any tracheal deviations, tracheal tuck, and cricosternal notch. The distance, I mean.
It's normal.
Okay, so where is the pictures?
Okay. The Dr. Bazin will show you the picture. Sorry.
Okay, so could you please sit for me? I'm going to start to examine you from your back. Is that okay with you?
Okay.
Okay, so just look for the scar. Where is the scar? I didn't see it. The picture. I'm going also to do chest expansion for these patients above the scapula, at the level of the scapula, and below the scapula.
It's normal.
Okay, so the percussion. The percussion?
Percussion is normal percussion too.
Okay, normal in the both side. Okay.
Yes.
So I'm going to start auscultations. If there's any for the breathing sound, any added sound.
Normal. Dr. Bazin, that's not the scar. That's not my picture.
Yes,
Continue.
I just
Yeah.
share it. You can see it, Dr. Sarah now. Sorry, this is not yours. Oh, sorry. By
Yeah.
mistake. I'm so sorry. Okay, wait.
Okay, no problem. Yeah. Okay, so go the regarding the auscultation, is there any finding, any added?
No finding.
Okay, normal physical breathing.
Yes.
Okay, so the focal resonance, please say 99 for me.
99, normal.
Normal. Okay.
Yes.
Okay, so
Now you can see it, right?
no.
Here.
Okay. Okay. This is 3 scar or 4 scar. It is okay.
Okay, I will add 1 more minute for the delay. You can
Yes.
continue.
Okay. Yes. Okay. So I'm going to do a similar examination in the front of the patient if there is any significant.
No. No.
The lymph node.
No lymph nodes.
Okay. When the patient sitting, if there's any sacral edema, any any lower limb edema.
Normal. No lymph node.
Okay. Okay. So thank you, Mr. John. So I covered the patient and thanks him. You can take a rest now.
Okay.
Okay, examiner question, Dr. Henry.
Tell me present the physical findings of your patients and differential diagnosis.
Yes. I have examined Mr. John, 45 years old. Yes, who presented for follow-up in our examinations. The trachea is central. The patient lying on 45-degree. Trachea is central. Regarding chest expansion, normal. And regarding the percussion is resonance in both sides. And also by auscultation, there is normal ventricular breathing. Apart from a normal focal resonance, apart from that, I didn't find any other examination. Just when for the inspection of the patient, there is a small multiple scar, I think in the left side of the patient or the right side of the patients.
That's
Yeah.
right side.
Right, yeah. It most likely it could be a video assessed thoracostomy scar.
Okay. Any other thing? What's the differential diagnosis of the scar? Which other thing scar would that be, if not VATS?
Yeah, it could be lung volume reduction surgery, or it could be lung biopsy, or it could be segment segmentotomy. Okay.
No. Okay. My question: what other scar would, if not VATS scar, what could it be again?
Okay.
Of the scar.
Other scar. It could be just drain. Okay. Scar. Tube. I mean, just tube drain scar.
Okay. So, investigation. What are the underlying cause of the VATS scar? If it's the VATS scar, what is the underlying cause?
Yes. Underlying cause. Yeah, it could be due to lung biopsy, and it could be due to also lung volume reduction surgery, and also it
In
could
this
be
patient,
due to it might be lung biopsy.
one.
Might be.
What else?
What?
What else?
Or bullotomy. Bullotomy.
Bullectomy. Okay, 2.
Bullotomy, yes.
Okay.
Mm-hmm.
What else?
Other indications. Yes, lung volume reduction surgery.
Okay, fair enough. Okay, how will you investigate this patient?
What?
How will you investigate this patient?
Yes, apart from basic investigations, I will do for this patient chest X-ray, high resolution CT, also bone function test if needed.
Okay. So if, let's say, for instance, you are dealing with, it is not this question. Let's say the patient has had a lobectomy, not this patient, but just a question now. Has had a lobectomy. What are the chest X-ray findings of a lower lobectomy you see, of a lobectomy you see on chest X-ray?
Finding of lobectomy in the chest X-ray.
Yeah.
I didn't sure actually.
Okay. Then if it's a pneumonectomy, what are the chest X-ray findings of pneumonectomy?
Whitish whitish appearance in the X-ray.
What is the word? What is the word? I don't know what is whitish. What does the word? What will you see?
I forget it. I
Okay.
didn't remember it. Yeah.
Okay. It's okay. One more question. How will you, if it is a, let's say, dextrocardia, for instance, how will you differentiate? Or what do you see, or what will you see on chest X-ray if it's a dextrocardia?
What?
If it is situs inversus, like dextrocardia,
Okay.
what will you see on chest X-ray?
What I listen in the chest?
Chest X-ray, what are you going to see in a patient with dextrocardia? Let's say situs inversus, yeah.
There you are. Yes. I didn't get you regarding your questions. Yes,
I'm
in
saying,
patient.
let's say, for instance, this patient has
Yeah, what other finding you
dextrocardia.
could find if this patient is situs inversus or
Yes.
dextrocardia?
What are the X-ray findings?
Other findings.
Okay, the apex beat, it could be in the right side. Okay.
Okay.
Yes, and if it is associated with any bronchiectasis, course crepitations or not.
Okay, it's okay. Fair enough. Let me just, Dr. Bazin, can I give my own contribution?
Yeah. Go ahead.
Thank you very much. Your issue was okay. Your issue was okay. In fact, your diagnosis was correct. You got the VAT. It was a VAT scar. But for in the history, I would have expected you to, before you face the examiner, you should have washed your hand since you finished talking, examining the patient before facing the examiner. That shows that you've done, and you want to present your case. And then you didn't ask me if I'm feeling any pain in my tummy when you're checking my JVP. You didn't ask me for any pain. You just touched my tummy and examined the JVP. That is another one during the examination. And then for the diagnosis, which was you got, it was a VAT scar. Other differential diagnosis of that scar, it could be a robotic assisted thoracostomy scar, which is a rat scar. Robotic assisted thoracostomy scar. That's it can also be a rat. It could also be a recurrent pleurodesy, or probably what do you call it again? Pleural aspirate. Probably the patient has got multiple pleural aspirate. They took one from the first site, took one from the second site, and took one from the third site. So these are the three differential diagnoses you see in this patient: a VAT scar, a rat scar, or multiple pleural aspirate scar. These are the three differential diagnoses in this case. Then they also ask you a question: what are the X-ray features of a pneumonectomy? In pneumonectomy, in X-ray, you see the trachea will deviate, just like what Dr. Bazim said in the last question. On X-ray, there will be tracheal deviation to the affected side on chest X-ray. There'll be radio opacity in that particular side of the
Yeah,
wound.
obesity. I mean
Yeah.
obesity.
Yeah. Then if it's a lobectomy, you may also see what a what they call a rib recession on this on chest X-ray. You see bleps. Sorry, rib reception too on that part in which the lobe was excised. You see some receding. There'll be rib receding there, receding of the ribs. That's the one thing you see on chest X-ray, basically. Then for the last question I asked in terms of if it's a dextrocardia patient, what will you see on chest X-ray? You see there'll be, the gastric shadow will be in the opposite side. Instead of it to be in the left side, it will be in the right side. And then the heart border, the cardiac silhouette, which is the heart border, will be deviated, will be on the right hand side instead of the left. Basically, that is just the answer to the questions. Thank you very much. Dr. Bazim, over to you, sir.
Yeah, thank you, Dr. Henry. Nice comment. So let's repeat the last comment, which is very important. How to differentiate between dextrocardia and situs inversus. So dextrocardia only for the heart shadow or the cardiac shadow would be only to the right side. But for the situs inversus, the whole organs will be in the opposite side. So the gastric shadow will be on the right side. Okay, this is what he means, right, Dr. Renee?
Yes,
Yeah,
sir.
this is in conclusion. I thought you are asking about the chest or the lung finding while doing examination. So
No,
you
sir, it's
might,
chest X-ray.
yeah, the X-ray. Okay. So what do you think, Dr. Sarah, about the finding in the chest examination while having situs or dextrocardia? Lung
Chest,
examination.
lung examination, chest finding. Yes, just sometimes society's bronchitis is in carcinoid syndrome.
Exactly. Yeah, that's enough. Yes, this is what I want from you. So bronchiectasis as a finding complicating the main disease, which is for example Cartagena syndrome. So the patient might have or primary ciliary dyskinesia, right? So the patient will have bronchiectasis. Definitely, the finding will be going with bronchiectasis. Coarse crackles. You might have also the restricted or limited expansion, and the coarse crackle, as I mentioned, which will not, will be clear or will little bit disappear with the cough, right? Or will significantly clear with the cough. The other finding in the X-ray, what do you think the finding in the X-ray related to the lung as a bronchiectasis? Tram track appearance, right?
Yes, tram
Yeah.
trunk appearance.
Yeah, and in the HRCT chest?
In the CT, signet ring appearance.
Yeah, so yes, you have to mention it. Let's go back to the scar, VATS scar, video assisted thoracoscopy scar, right? What do you think the indication? What the differential? So the differential will be the same answer of indication. Why you are doing VATS?
Either lung biopsy
So in the better way, you can
or lobectomy or
divide it as diagnostic or therapeutic,
therapeutic, yes.
right? Sometimes they are doing it just to get a biopsy, either lung or pleural.
Pleurectomy, yes.
Yeah, so or pleural biopsy. And in the other, or mass biopsy, so lung, mass, or pleural biopsy. And the other arm will be for the therapeutic. What do you think is the therapeutic indication, or why I'm doing VATS?
Lobectomy, bluectomy, lung
Yeah.
volume reduction surgery sometimes.
I don't think the lung volume will be, maybe wedge resection, because they are crushing, yes, the lung or the lobe or the part of they want to remove the wedge, the area of the removal. They can crush it and absorb it. Polarectomy or lobectomy or bulectomy or polarectomy. You mentioned polarectomy, yes, or even for recurrent pneumothorax, the same as polarectomy, pleurodesis.
Bluectomy, yeah.
No, bulectomy for
Bulla.
bullous. Bull, yeah. No, but for the pneumothorax, they can do the pleurectomy itself or
Pleurodesis.
pleurodesis, yes. Okay, these are the diagnostic and therapeutic formats. Or there is fusion, for example, they can also remove the fluid. Simply, you can divide them in this way, and easily you can enumerate both of them. Yes, they can go for the question of pneumonectomy or pleurectomy. What the indication for this and what the indication for that, and how to differentiate the pleural effusion. This is very important type and topic. What are the differential of pleural effusion?
نعم يا حبيبي.
Sorry.
It could be infection, malignancy, pneumonic effusion.
No, okay, yeah. How to
Exudate.
no, give it scientific differentiation. How to differentiate and to say this is infection, to say this is
Transfudative and
cancer, based on criteria.
transfudative. Yeah, transfudative and exudative. Light criteria.
Sorry.
Light criteria. According to the light
Again.
criteria.
Exactly. Yeah. So transudate, exudate, light
Yeah.
criteria. Exactly. So mention it. Yes, based on light criteria or protein. You can say protein earlier if there is a protein level between 25 and 35. You have to do or to apply light criteria. If less than 25, this is exudate. If more than 35, this is
This is transudate.
yeah, or the opposite. Sorry, I mix.
No,
Yeah,
I don't
yeah, more than 35 exudate, less
it
than
is exudate,
transudate.
let's 35, yeah, transudate.
Yes. In between, so you are in the gray zone. That time you have to apply light criteria. What are the light criteria? Divide what?
The serum,
The
serum protein or albumin, compare with the pleural fluid albumin. Divide it if
okay.
more than 2/3
Yes.
or more than 50.
Continue. 2/3 or 60.
The LDS
Okay.
show albumin. Yeah, the albumin more than 50 and the LDS more than 60.
Yeah. So the pleura, not the serum first. The pleura first. The pleura divided by the serum protein. Let's start with the protein. If the pleura more means this is exudate, more than 0.5, so more than the half. This is exudate.
Yes.
Or the LDH more than 0.6, the pleura again. Or the pleura, it's LDH more than 2/3, the serum one. All this going with exudate. Okay, whenever you have protein between 25 or 35, you have to apply light criteria. Okay, what about the infection? Or what is the single criteria for the infection? When to say this is empyema?
BH.
Yeah, the pH. Yeah, how much?
Less than 15.3 indication for
7.2. 7.2. Empyema. Okay, this is
7.2.
yes, yes. So this is indication of drainage and antibiotics. Okay. Be ready also to be asked about the pneumothorax, how to approach the pneumothorax, and when to do pleuresis or pneumonectomy. Sorry, pleurectomy or pleurodesis in case of pneumothorax. When to do it. Dr. Sarah, when to do pleurectomy in case of pneumothorax? When to do pleurectomy or pleurodesis in case of pneumothorax?
If it recurrent
Yes, exactly.
or high
So
risk situation, yeah.
no, any recurrent. This is this is the most important answer. Any recurrent pneumothorax can be or need to be done as pleurectomy. Okay, and you have to know also the criteria: when to aspirate, when to admit, when to follow and monitor, and when to put a chest tube. Simple simply, whenever the patient is symptomatic, short of breath, or having high size pneumothorax, the chest tube is indicated. If the patient is asymptomatic and the size is high, you can do aspiration. If failed, you can insert chest tube. Okay, the empyema itself is an indication for chest tube. Don't aspirate only; it will accumulate again. You have to put chest tube. Okay, clear for all?
Yeah, clear.
Yeah. Anyone want to add any point we missed? Any differential we missed? I will go back to
Just
the
please,
pneumonectomy.
could you please repeat the test finding
Chest
in the
finding.
lobotomy and yeah,
Okay. Let's start from the
and
inspection.
pneumoctomy,
We will
apart
do it
from
from the inspection, from the start, even not from the end of the bed. While you are standing at the end of the bed, what you can find in the chest examination.
yes, asymmetrical
Exactly.
chest movement.
Let's do it in the whole steps. Because we just mentioned the part related to the X-ray or the scar, but we will
Yeah.
start from the beginning. If you stand at the end of the bed, there is a limitation or asymmetrical chest expansion, and give me a cough. You find the chest is moving toward one side or rise in one side. You might suspect this is a pneumonectomy case. Okay. Why? Because the pneumonectomy means you are removing the whole side. Means that this side will be empty and the chest will be little or less expanded on this side. We didn't do anything, just from the end of the bed. Now we will go to the back inspection. The first thing you will see toward the pneumonectomy will be from the back. The scar. The scar. The scar will be big scar, maybe from the anterior border to the posterior border, parallel to the chest wall. By the way, pneumonectomy scar is bigger than lobectomy scar. Okay, it will be very extensive one from the start or from the anterior to the posterior, the end of the rib. Okay, let's continue examination. The inspection we finish at the scar. Now we will do the palpation. The expansion again, it will be limited more with the pneumonectomy. Okay, we didn't say this is lobectomy still. We can say maybe this is lobectomy. Now we will do the other steps that will guide us to the pneumonectomy. The percussion itself. You will do the percussion. What you expect the percussion with the pneumonectomy?
Darkness.
Dullness in the all sides, right?
Yes.
Lobectomy, you might have some resonance unless there is other pathology in the other lung loop, like for example, fibrotic lung. By the way, they prefer to leave the fibrotic lung rather than removing it. Why? Because it will fill the area of this lung. So they might remove part or lobe and they will leave the other. But for the pneumonectomy, if there is pathology in the whole lung that might be, for example, cancer, they can remove the whole lung. And you might have as I said, limited expansion in this side. And the percussion will be dull in the whole side. But the lobectomy, you might have some resonance at the area of the reserved lobe. Or even though you might have hyperresonance. Why? Because of compensatory hyperinflation of the other lobe. But you will still have the scar. So you suspect this is a lobectomy scar rather than saying this is pneumonectomy. Whenever you have air entry increase or there is air entry in the side of the scar, definitely this is not pneumonectomy scar. So we differentiate between both of them in the inspection, in the palpation. Now with the auscultation, so you might have air entry or decreased air entry, but in the pneumonectomy, you will not have any air entry. So you will have all over or globally reduced air entry. And in the lobectomy, you might have some air entry, some you might have bronchial breathing, okay, for the cavitation or for fibrosis. But for the pneumectomy, as I said, you will not have any air entry. back to the vocal resonance. If there is consolidation or there is fibrosis, for example, cavitary lesion, with the lobectomy, you might have increased vocal resonance. While in the pneumonectomy, you will have decreased vocal resonance, right? Dr. Sarah, clear?
Yes,
So
yes.
the whole steps now from the back we did, going, it will either differentiate between this or that. Let's go to the front. And suppose you do the trachea examination earlier, but I start from the back, but the trachea will also guide you. So the trachea will be deviated or shifted toward the side of pneumonectomy. And you will also do the other steps of examination to confirm this is pneumonectomy, as I mentioned earlier. So it's not only trachea deviation. Why? Because sometimes with the lobectomy, along with lung collapse, so the patient might have lobectomy and the other lobe collapsed or fibrotic, and the trachea will be deviated. Okay? Or the patient will have lobectomy, the other lung lobe will be healthy, and the trachea will not be deviated. So you can say with the pneumonectomy, the trachea definitely will be deviated. Lobectomy by default, suppose not to be deviated unless there is lung pathology in the other lobe and early surgery or just now the surgery done. So you might have the trachea deviation. But by default, with the long term, the lung will be expanded and the trachea will be centralized. Clear now? Dr. Sarah, that the pneumonectomy definitely will be deviated.
Mm-hmm.
But lobectomy supposed to be centralized unless unless you have collapsed lobe or pathology in the upper lobe. Okay, so either this or that. Otherwise, supposed to be in the central. I hope you got it.
Yes, yes, Dr. Basu. Thank you very much.
Okay, so pneumonectomy definitely it will be deviated. Lobectomy supposed not to be unless the surgery just now done. So the patient they remove the trachea, the lobe, and the trachea will be deviated. With the time, the trachea will be centralized again. Or there is apical pathology and the other lobe pulled the trachea toward it, and it would be the case. Let's talk about the trachea shifting, as we are talking about trachea shifting. When you will say this is trachea deviated to the contralateral side, what the only situation the trachea will be deviated or shifted to the other side? Dr. Sarah, two situations, not one.
Pleural effusion pneumothorax.
Yeah, massive, not only pleural effusion.
No.
Massive pleural effusion or tension pneumothorax. Okay, so either fluid push it or air push it. And now that the pathology will be in the other side. Clear? Contralateral, I mean. Before we are talking in the same side, ipsilateral, pneumonectomy or the scar or whatever, or collapse. By the way, as Dr. Henry said, either with a scar or without a scar. If there is a scar, as we mentioned, pneumonectomy, lobectomy, or no scar, so you have to say this is collapse or fibrosis. Clear now?
Yes, clear.
Okay. Any question, Dr. Sarah or Dr. Henry?
Thank you.
Thank you very
Dr.
much,
Basu.
Dr. Lazim. Thank you.
Yes. Yeah, most welcome, Dr. Anyone want to add any comment? Yeah, I think the comment are correct. So recurrent pneumothorax is an indication for bilirectomy or bilirhodesis. And the Dr. Marwa also commented that. So clear, yes. Thank you. Effusion also. Yes, as you mentioned, effusion or tension pneumothorax. Don't say only effusion. they're supposed to be massive or moderate to massive pleural effusion. By the way, some cases coming as pleural effusion, and you will have stony dullness in the base or at the base of the lung. Okay. So the finding, and the lung case or the chest case supposed to be clear. I don't think anyone will be have conflict about it. Either scar, which is very good and lucky patient, lucky to have this patient. Scar, easy to pick up and easy to answer the questions. The indication, as we mentioned, or what the differential and so on. Or you might have obstructive lung disease or restrictive lung disease. Okay? Or you might have pleural effusion. Obstructive lung disease, of course, you have to speak about COPD and asthma and bronchiolitis obliterans. And you will have peripheral signs, sometimes respiratory failure, cyanosis. Or the other type, which is restrictive type. So you are talking about the fibrosis as idiopathic. Patient also might be on oxygen or interstitial lung disease, whatever the pathology, either rheumatoid arthritis, medication, or a connective tissue disease, or even the occupational or ankylosing spondylitis or radiation. All these for the restricted. So either obstructive or restrictive lung disease or scar or pleural effusion. Don't forget yellow syndrome, yellow nail syndrome. You might have the effusion with yellow nail. Okay, bronchiectasis also you can put it one of the mixed, either restrictive or obstructive, but mainly restrictive. Clear now?
Dr. Bassem, the last
Yes.
case came before in the exam, or because for me strange.
Sorry?
Last case of Dr. Henry that Dr. Sarah presented came before. I mean, came before an exam. I mean,
the pneumonectomy? The pneumonectomy?
no. The other case, the second case, it was only scars.
VATS, yes. It came.
Came before.
Yeah. And also it's lucky
will
case.
be the open discussion for the indication, yes, or what?
Yes. What the indication, the effusion, the pneumothorax. And the case is present in the BAS medicine, by the way. BAS test. VATS scar. You can watch it. VATS scar. So you have 3 ports and one major scar. 3 ports and one major scar. What the indication? So they can get biopsy as diagnostic or therapeutic. And according to the underlying, they will speak with you. Either pleural effusion and the criteria of pleural effusion, how to do, what to do, infection, cancer, or the pneumonectomy itself, what the indication and how to approach the pneumothorax, when to admit the patient with the pneumothorax. Sometimes they might go through the flying even. The contraindication of, for example, the pneumothorax to fly, when the patient can fly, and what instruction you can give to the patient with pneumothorax. So the diving, the flying, or hiking. Okay, all this you have to mention. The scar is the easiest case ever in the exam, because you will know what about the question and the discussion. Either liver or kidney or lung or biopsy, VATS. So any patient with the scar, you will be lucky to have it. Okay. I didn't mention the clamshell, which is for the transplant. Some countries, they have transplant, so already, according to the center, sometimes they brought the clamshell for double lung transplant. And they will talk about the indication, the contraindication, the complication. Okay? Don't talk about the complication as only one complication. Always talk about systemized answer. Don't speak about one single. You can talk a lot about the surgery, anesthesia, the compliance, the complication you are talking about, the disease itself, the infection, the transplant itself, rejection, infection, recurrence, the immunosuppressant medication. Always start with this systematic answer, and definitely you have good mark. But if you start saying the only the points which, like for example, what I know about the side effect of the transplant, you will speak about the rejection. But don't forget there is also some other complication. Or you can say cytomegalovirus infection. Okay, what about the other infection? So speak in general. Give a major and headlines. Then try to, if he asks you, what do you know about this? You can speak about it. Okay? Anyone want to add any comment or question or to ask? Jordan, do lung transplants. Okay, good to know. Thank you. So anyone in lung in origin Jordan, be ready for the lung transplant. And it's easy case also, by the way. It's not, the transplant is a good topic. Even while mentioning the multidisciplinary team approach, you have to mention the transplant team, the infectious disease, if there is infection, possibility of the infection, or the pulmonology, or the cardiac, or the, for example, if there is respiratory therapist indication. So it's easy to speak, but you have to take a breath before starting the answer. Whenever you start to enumerate without thinking, you will have a lot of mistakes. Okay? Okay, you're asking, I don't know, really, which center or which countries they have, I don't know. But there is recalls in the recalls group about every center. Everyone can ask in the recalls group, subgroup in my community. Anyone want to know his diet or the previous diet cases, just post a question, and I will post what the center is having. I'm talking about the recalls. This collection already from previous diets. Okay. Usually in Jordan Center, liver transplant is very common. I think what I know in Egypt, they don't have liver or lung transplant. This is what I'm sure about. In Egypt, no liver nor lung transplant. Maybe there is kidney transplant, but I didn't hear about lung. Although I'm not sure also, maybe there is, but the common that they don't have it. But again, please don't stick to my words. Anyone want to have the recalls for his center or her center, there is a recall group. Join through the community. Okay? Any other question or comment? Anyone want to comment? Okay, thank you, Dr. Henry and Dr. Sarah. See you tomorrow, inshallah, with long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.